and welcome to They Say It Takes a Village. My name is Raya. I've got 2 little boys, a full-time job, and now I'm adding amateur podcaster to the mix. So it's safe to say that it really does take a village, at least for me to raise my kids. This podcast is aimed to give moms a fun, unfiltered, and an informative outlet to navigate all things motherhood. Join me each week as I interview one of our local heroes from my village who make mom life just that bit easier. Think of me as your personal mom group, bringing you recommendations when you need it the most. Having said all that, let's get into today's show. They say the best protection is early detection. Hello and welcome to another episode of They Say It Takes a Village. Today, I'm very honored to be joined by Mediclinic's breast radiologist, Dr. Maha Al Marashi, as we discuss breast cancer awareness, early detection, and how crucial it is for women and society as a whole to be informed. Dr. Maha, thank you and welcome to They Say It Takes a Village. It's such a pleasure having you on.
Thank you so much for having me. I'm honored and the pleasure is all mine.
Oh, it's just, I know how busy you are. And I know that obviously, being October, it's one of, I'm sure there's 1,001 events that you're doing. And I'm just so grateful that you're here.
No, thank you. Thank you. Happy to be here.
Do you want to tell the listeners a little bit about yourself, what you practice, and just a little bit of a background?
So a bit of a background about me. I did most of my medical training abroad. So I've been out of the country for about 22 years.
Wow.
Just freshly back this May. And it's really nice to come home. I was in Ireland for about 15 years.
My goodness.
Did all my medical training there. Worked all my way up into even having done a stint in breast surgery during my surgical training phase. But I was in the UK for the last 6 or 7 years, actually.
Oh, wow.
And did all my radiology training over there. And the last basically year and a half of my training, I was just purely doing breast subspecialty training in Macmillan Cancer Centre.
Wow.
And I did work as a consultant in one of the trusts in the UK as well. So yeah, it was really nice to come back and be home and help the people here now.
That's right. And now you are here, based here, Mediclinic.
Yeah, it's great.
Amazing. Obviously, I mean, we are in Breast Cancer Awareness Month.
Yes.
And it's one of these things that I feel everybody is always a bit nervous around, and it is a very, very, very important topic.
Yeah.
And of course, for you as a breast radiologist, this is something that you're sort of that's the crux of what you do.
That's
on a
all I
day-to-day.
do.
Yeah. So as a what is the role of a breast radiologist?
So my job essentially is to look at imaging for the long and short of it. So I look at mammograms, we scan ourselves, so we do the ultrasound scans ourselves, MRI scans as well. We report on those. If there's any procedures to be performed, that is image guided procedures, we do those as well.
Okay.
And if we are guiding surgeons pre-operatively, we also help localizing lesions.
Okay.
Which means we insert markers or wires into a lesion that will aid in guiding the surgeon towards an area that's not felt, so that they better know that this is the area I need to take out if they're just doing a simple lumpectomy.
Okay.
So quite heavily involved in most of the early parts of treatment of breast cancer, but we also just monitor as well after that. So we do follow up.
It's a lot.
Yeah.
That's it's all encompassing, I feel.
Yeah, it is very
and you
much
work,
so.
I think, closely hand in hand with breast surgeons.
Yeah,
and
with the breast surgeons, with the oncologists, with the patients, with the nurses, with the mammographers, with the sonographers if they're available. You have to. Yeah.
I mean, I think a big one. I mean, to break it down into basics.
Yeah.
What exactly is breast cancer?
So,
I mean, I know that might be, the biggest sort of trying to make sort of a huge topic into something tiny, but what is it really?
So breast cancer, like all other cancers, is pretty much a bunch of abnormal cells that start growing.
Okay.
And each cancer is going to be different. So for the most part, they can start off as in situ cancer, which I'm sure you've heard of before, which means they're still very much not gone anywhere. They're still in the breast. Once you have
almost contained.
Correct. Yeah. Very treatable and very good prognosis. Then you have, once a blood supply starts growing, then you have an invasive component. And then there's a potential for spread. And there's different ways that it can spread. It can spread to the lymph nodes, first of all, and then it can spread to other parts of the body as well. Obviously, our job is to catch it before it goes anywhere.
Okay. So at that sort of contained phase, in
Ideally,
situ
yes.
phase.
Ideally.
And so when it comes to that, does that have any relationship between the different staging of cancer? You always hear about the
Yeah,
staging.
it does. Yeah. So
Okay.
absolutely. So when we talk about staging, we are basically talking about TNM staging,
Okay.
which is the tumor size, the number of nodes involved, and if there's any metastasis. So TNM, very straightforward.
Okay.
And that's the acronym.
Okay.
Tumor size, we break it down into 4 parts.
Yep.
So it's under 2 centimeters, T1.
Yep.
Between 2 and 5, then that's a T2. More than 5, that's a T3. If there is skin or muscle involvement, that's a T4 cancer.
Okay.
Then we go on to see, so you have your T stage, then you look, are there any lymph nodes involved?
Yeah.
And then depending on the number of nodes, and 1, 2, 3, and then if there's metastasis, and 1, 2. So that's essentially
What?
the same staging system applies to many other types of cancer,
Okay.
but it works just as well for breast cancer as
Yeah.
well.
Now, of course, I think everybody sort of hears that, they'll talk about their mothers or grandmothers or aunts or whatever it might be, potentially having
Yeah.
sort of a genetic factor of breast cancer.
Yeah.
So, what are generally the risks or causes really? Is it just at random, or there is a major genetic component?
There is a genetic component, but it's
Okay.
not a major component.
Okay.
So 75% of cancers that do occur don't have a family history.
Oh, wow.
Yeah.
Okay.
So there is that. So there is a misconception, but everyone in my family is fine. There's no one who has it. I'm like, that is true, but there's nothing stopping any of us from becoming the family history. So it does start somewhere sometimes.
That's right.
There is a genetic link. Obviously, we all know Angelina Jolie's story.
Yes.
She did her testing,
Yes.
she found out, and it's all about risk. So when you do genetic testing, you're calculating your risk of developing breast cancer. It doesn't necessarily mean you're going to get it, but there's a higher risk of getting breast cancer. And ovarian as well, depending on which BRCA gene you're getting. So 60% increased risk for breast, 40% increased risk for ovarian cancer. But there's other factors involved as well. There's breast density. So the more breast tissue we have, the higher the chances as well. The less active our lifestyle, smoking to a certain degree. Studies have shown alcohol as well can result in this. If you've had a longer period of exposure to hormones, whether it be in your own body. So if a person's had a period below the age of 12 and continues to have periods over the age of 55, so you were exposed to those hormones for quite a length of time, then that puts an increased risk. Not having children, because you're constantly exposed to your cycle hormones. So having children is protective.
Goodness.
Breastfeeding is protective.
It's
So having
protective.
never breastfed is also a risk.
Okay.
Some types of oral contraceptives, some types of hormone replacement therapies. So there's quite a few things that could cause breast cancer.
Yeah. But sometimes it could potentially be just because.
Yeah, because you
that's just
have
the way it
women
is.
who are healthy lifestyle, no family history,
Yeah.
have had your 2.5 kids, has breastfed them, not smoking, not drinking alcohol,
And
but-
then they've come up with
and they could develop it. So there's no kind of one tick box to say, well, I've checked all these boxes, I shouldn't get it. There's no prediction.
And it's a bit of a worry, because you do think that if you lead a certain lifestyle and there isn't a sort of a genetic component, that maybe your likelihood of doing a self-test or checking might be lower
It
than
is.
if somebody has potentially been exposed
But
to it.
that's
in
what
their
it is. The
family.
likelihood is lower.
Yeah.
Right? So, but it's still there.
Yeah.
It doesn't take it away. So that's where a lot of some of the misconception comes from. Like, I'm very healthy. My
How could
BMI is
this
perfect.
happen?
How
Yeah.
could this happen? And I can understand the shock, especially if someone's saying, well, I'm vegetarian. I've stopped eating everything. I grow all my food, and I know hormone comes into my body. The chickens I've grown well, yeah, fantastic lifestyle. But then,
There are other
there
things.
there are other factors involved. They
yeah.
can happen de novo as well,
Yeah.
which means spontaneously. Yeah.
It's important to know that.
Yeah,
Yeah, it's
absolutely. Yeah.
important to know that. Even again, speaking from a personal point of view,
Yeah,
I try my best to lead a sort of a healthy
absolutely.
lifestyle, and I've come to you because I had a little bit
Yeah.
of a family history and worried from it. But
Mhm.
should I have not had a family history or a scare,
Yeah.
I probably wouldn't come.
Yeah.
And I would probably think it will be fine,
And I can wait.
and I could wait,
Yeah.
and that may be a big misconception from my end.
I mean, in a way, if you're not sure of something and if
Yeah.
you're actually worried about something, that's what's going to drive you to get checked.
Yes.
But if you're gonna go on the back of I'm leading a healthy lifestyle, I don't need to check,
It
then
may
that's a
be.
choice
Yeah.
that you can make. But then you'll never know 100%. Like there's no guarantee in life anyway. But
Absolutely.
it's just that added bit of no one can really give you that 100% reassurance
Of
unless they've
course.
examined you or seen you.
Absolutely. Yeah.
So yeah.
But speaking of like a guarantee,
Mm,
genetic testing
yeah.
or screening,
Yeah.
is that a possibility? Is it a recommended possibility?
Depending on the family history. So
Okay.
at the moment with genetic testing, like for a person to get it paid for through insurance, obviously, then there needs to be a significant family history of like first degree relatives that have been involved.
Got
There's
it.
nothing stopping anyone from
Walking in and
walking
getting
in
it.
and getting it
Yep.
themselves if they're happy to pay for it. For better or worse, if you do get a genetic test, you need to kind of mentally prepare yourself with what you're going to do with those results. So I tell my patients, well, you need to kind of be aware that if you do get a result saying, yes, you have it, what are you going to do? Are you going to decide to go screening? Are you, which is just doing the annual checks, which there are programs in place for people who are high risk. Are you going to go down the route of what Angelina Jolie did and take everything
So
off?
proactively.
Right.
Yeah.
So it really is one of those things when I think people do decide that, oh, I'm going to go and do this, they don't realize the weight of it. It's great if it's negative.
That's right.
It still doesn't take away, it doesn't guarantee that you're not going to have, or someone isn't going to have breast cancer. But then what do you do if you do test positive? Because now you have a decision to make, right?
Yeah.
Which road are you? So it's all about being informed and knowing what your options are. I think you really need to
Sort of
know.
have a good think
Yeah.
before you take the first step.
Yeah,
kind
I
of
mean,
thing.
do it by all means.
Yeah.
If you're that, it's all personality types as well. Some people want to know, some people don't. But when you have that knowledge, what are you going to do with that
Yeah.
knowledge?
It's a bit of a balance, you know?
Absolutely.
You want to be informed and you want to be aware, yet
Absolutely.
also at the same time, you have to be realistic about
Yeah.
what the situation actually is, you know? Yeah. It's difficult. It's so delicate as well.
Absolutely.
Yeah.
There's no right answer.
No,
Yeah.
no. And let's say, for example, when I know all different parts of the world have different times or different ages where women should start officially screening. Is there a recommended? I mean, should we discuss, for example, the recommendations here in the UAE,
Yeah.
as opposed to other places around the world? Is there a general idea of when women should start screening?
Yeah, so there's a lot of debate on this as
Yeah.
well, like because there's obviously different programs in Europe and America. So if you look at the American guidelines, they talk about annual screening from the age of 40. Some countries in Europe will talk about every 2 years getting the screening. I was in the UK, we did our screening every 3 years.
Okay.
So it's all about looking at the demographic of patients that you're dealing with as well. So demographic of patients in the UK may be different from the demographic of patients in Europe, which will be different from the demographic of patients we have over here. We know here that breasts are more dense in this region of the world.
That's going to be one of my questions later
Yeah,
on.
no,
Yeah,
no.
yeah.
So because of that, the more breast tissue we have, obviously, the more likelihood then we're to develop breast cancer. So
Yeah.
there's talks of screening at a younger age. But
Yeah.
then when you're talking about screening, how you're going to do this, are you going to do ultrasound isn't really a reliable screening tool. So we're
Okay.
going to go mammograms. But then if you're going to do mammograms, you need to do more specialized imaging for it as well. It's very tricky, right? I'm currently here. What we're doing in Mediclinic is we're screening from the age of 40 with mammograms
Okay.
every year. So I recommend to patients doing it every year. So I'm happy with this
sort
for
of
now,
guideline.
for
Yeah.
as a guideline, absolutely right. We just need to wait on more kind of like studies, more trials to be to come out from our region, so we can give a more accurate or a reliable recommendation before we sit there and speculate. It's easy for
That's
anyone
right.
to speculate.
Yeah.
So yeah, with an annual checkup, I think from the age of 40, starts with that.
And that would be sort of anyone, regardless of
Regardless.
genetic
Absolutely. God, yeah.
predisposition.
No, no, no.
Okay.
Regardless, screening from the age of 40, standard.
So again, I always think so the screening in terms of actual an imaging sort of method of screening, but then you can potentially start by sort of like self-examination.
Absolutely.
And does that have I mean, I guess what I mean to say, when should women be kind of concerned, or not concerned, but it's a little bit more on their minds to do a self-check? Because
Yeah.
I mean, you're not going to have, I don't know. I mean, even me in my 20s,
Mm.
I wasn't thinking about
No
it.
one does.
Yeah.
No
Yeah.
one thinks about this in their
Yeah.
20s. I mean, honestly, you're going to have to look at the time in which the breast types stops developing.
Okay.
So you're thinking roughly around early to mid teens, 20s, excuse me,
Yeah.
would be the best time to start,
Oh, wow.
because the
Okay.
breasts at that point would have developed.
Yeah.
So you want to do it at a time when the growth has stopped.
Okay.
We still get young girls coming in with lumps,
Yeah.
right? So that is quite normal. But then obviously, if that's the case, come and get them checked. But if you're going to come do the check yourself, I think start early, because
Okay.
if you know what's normal for you, that's going to drive how you kind of take your breast care
Yeah.
going forward. But try and convince a 20-year-old that, you should be
Doing a self-check.
doing a self-check
Yeah.
like from at the age of 24, 25, and they have life and college and
Yeah,
exams. It's
yeah,
hard, but
yeah.
I think it's really important that women like really start normalizing that this is just part of the
Just like,
routine.
yeah, just like you would when you go and just get like a medical or
Exactly,
something else,
absolutely, yeah.
just a blood test or
People go in for pap smears.
absolutely,
right?
yeah,
So-
absolutely. It's true. Again, in my 20s, it just never even occurred to me.
Wouldn't have, no.
No, not at all.
Neither would it have me, to be honest.
Yeah.
It's only now that I'm a breast radiologist, I'm
That
like,
you're like, oh yeah, it's good to
It's
sort of
good to
almost have like a
start.
baseline.
absolutely, yeah.
Yeah, I think that's the key.
Yeah.
Do start early.
Yeah, yeah, yeah.
Yeah. Without being overly panicked about it,
Mm.
maybe.
Mm.
I think we were talking a little bit before we started that a lot of the times there is this misconception of, you know, breast cancer being absolutely devastating, and it could be sort of completely, I guess you jump to the worst case scenario.
Yeah.
When, it's just, it's one of these things that it may not be.
No, yeah,
Yeah.
absolutely. No, but that's it. Like with the fact that we have a lot more awareness these days than we would have back, say, 20 years ago.
Yeah.
And more women who've survived have come forward to talk about breast cancer and their journeys and the fact that they're still living on. I have family members who've had breast cancer who survived. I've had family members who've not survived.
Absolutely.
So every single one of us has a story of someone who's been affected. The key is always going to be catching things early, obviously. Early detection, again, is going to be what drives it. And not just early detection, but the type of cancer that they're. For the most part, the earlier we catch it, the better the outcome,
I see.
granted.
Yeah.
When people have had lumps that they're not sure of, that have stayed for a while and they haven't checked them early, unfortunately, in those circumstances, sometimes by the time they come and get seen, it might be spread to a lymph node, which changes the treatment. Because anytime there's a new
Step.
anytime you give it a chance to grow, it will take that chance. It will go forward. So the whole point of getting it early is to stop it in its roots. But for the most part, we have really good outcomes nowadays. The surgical techniques have improved as well. You have oncoplastic surgery. So even if a patient does go for something like a mastectomy, there's reconstruction that's done at the same time. So it's a one-step process, depending on, again, the type of cancer that patient has.
Yeah.
It could just be a simple lumpectomy,
Yep.
nothing more. It's a small bit of radiation, maybe a bit of chemo.
Yeah.
I mean, I'm
We
not
can
not
get-
to simplify
No,
it or
absolutely. But it's also,
belittle
yeah,
it.
it's not also, we live in an environment where anxieties have,
Normal, yeah.
yeah, it's they
The information is all
overloaded.
yeah.
And sometimes that's always another issue. Obviously, when people go onto Google and start to sort of sort of self-diagnose
Absolutely.
something, and that sort of sends them off in a tailspin.
Yeah.
And you've got people coming in with something could potentially be, if you have caught it early and something that is treatable,
Mm-mm.
you sort of remove the anxiety portion, leave it up to the professionals,
Yeah,
let them
yeah.
help you, kind
Yeah.
of thing. Yeah.
Yeah. Yeah. I mean, Google's only good in the hands that that use it, right? Like I still sometimes, obviously, I have to go to Google. Like there's papers on there that I
Yeah,
need to read, so I have
absolutely.
to.
Use it as a tool.
I use it as a
Yeah,
tool, but
yeah.
it's not.
It's not the be all and end all.
It's
You
not
didn't
the
get your medical
foundation.
degree from
I
there.
did not get my. Unfortunately, we did not have
No.
Google when I graduated. It was a long time ago, so or had just started, so there was nothing on Google.
Yeah.
But I tell my patients, I mean, it's hard. Like I tell them, I know it's going to be hard for you, but try as much as possible not to go to Google.
Yeah.
Like if you have questions, just ask,
Yes.
right? If you're not sure, just come and ask, because at the end of the day, let's be real, you have a cold, it's cancer. You have a
headache and it's some sort of
it's a
stroke
cancer.
or a tumor.
Everything
Yeah.
is a cancer.
Yeah.
It may be, but
Yeah,
even then,
yeah.
the prognosis isn't the be all and end
That's
all,
right.
right? So I
Yeah.
think when you sit and actually talk to professionals who can break this information down in a way that you're able to absorb it, and when we do it, it's not in one time, it's done over stages.
Mm.
Like we have to tell patients, I'm worried about this, this is suspicious, it looks like there's something there. So they only know that, okay, this could be a cancer, highly suspicious. I've sometimes flat out said this is a cancer.
Yeah.
You have to, if someone isn't grasping that this is
Something that we
serious.
need to
and I
look
have
into
to, and
and
I have
further
to add
diagnose.
the weight to it.
Yeah.
But then there's the question of, well, what type is it? Because that makes a difference in terms of what we're going to do.
Got it.
So that's when the specimen that we send to the pathologist makes a difference, because depending on the cancer type, the treatment's different, the options are different.
Mm.
We need to still complete further imaging. We do full body scans as well. We do MRI scans of the breast. We look at full extent. Is there any more?
Yeah.
How's the other breast? We need to be 100% sure of what we're dealing with before we go in.
That's right.
And it's only once we have all that information as clinicians that we can give you more information, and so that you can make the informed decision. Otherwise, it's pointless.
It's only getting half the story.
Yeah, not even. You're
Yeah.
just looking at the blurb on the cover of the book. Like,
That's right.
it means nothing. Yeah.
It's good to know. It's good to know. A lot of the times, I think it's great that you sort of almost mapped it out, because I think a lot of the times going into, getting a scan or a mammogram, it can be a bit nerve-wracking.
Absolutely.
But it's good to know that you've got such a team is almost cohesive enough to be able to
Absolutely.
kind of cover all grounds,
Yeah.
that you're not looking at it from just that and you're left to kind of do your own thing.
No,
Yeah.
it can't be that. Like
Yeah.
it is definitely a team effort. Every week we have what is called a multidisciplinary team meeting. We discuss all new cancer cases,
Yeah.
all the ones who've had surgeries, all the ones who are on treatment, any of the ones that we call indeterminate, so that it's not a cancer, but it's not benign. So we do have these conversations between the radiologists, between the surgeons, between the oncologist is there as well, the pathologist is there. So if there's anything that we need to clarify, we as a whole team are working together for the best interest of the patient.
That's wonderful.
And we have had disagreements,
Of course.
professional disagreements between two people and that's completely normal, because at the end of the day, we're all going to advocate for the patient. So it's the same
Absolutely.
mentality. So
Yeah.
there's no, and we're always getting ideas from each other. Or I could bring a case, say, this is a complex case. Can I get your opinion? I'm planning on doing this. Is this correct? And we make the decision as a team. There's no one person deciding the care of an individual when it comes to cancer.
That's right.
The decision is made by a team of specialists. And that just adds that added safety net for the patient.
Absolutely, absolutely.
Yeah.
It's so wonderful. The work that you guys do is incredible. But just to sort of, to go back to, for example, the self-assessment.
Yeah.
I think I've even asked you that
You have.
question. Is there a particular protocol?
So
Is there something that, should you be doing? I mean, is it something that maybe go in and have a chat with your GP or a breast radiologist, or, in terms of the correct way to do a self-assessment?
So obviously, yeah. I mean, I think the best person to ask how to do a breast exam would be a breast surgeon.
a
to
breast
be honest.
surgeon. Yeah.
To be honest,
Yeah.
right? I mean, the GPs are fantastic. Obviously, they do breast exams, but I think I mean, I don't expect patients to come out with breast surgeon hands, but
Yeah.
it's just more the
Almost like
actual
a technique.
it's the technique, right? I think we know it as well because we deal with it. So I always explain to patients how, when and how, because it's not just a how, it's when. Doing it too often is incorrect. Doing it once every 6 months is incorrect. Doing it while you're watching TV because I've decided I'm going to do it now is also incorrect.
Yeah.
So there's very much a correct way of doing it.
Okay.
My recommendations to all my patients who I'm giving an all clear and I'm sending home is essentially the best time to do it with regular, if a person has regular periods, is a week after the cycle. If they're on the pill, if they're on some implant device that is
hormonal.
exactly hormone treatment where they don't get periods, then just pick a day in the month. Usually the first of the month, everyone remembers.
Okay.
And that's the time you should really just examine yourself. It just takes 5 minutes. Once a month is enough.
Okay.
And out of the shower in front of a mirror, raised arm,
Okay.
and you need to kind of really look at the skin, right? It
Okay.
needs to be top naked.
Yeah.
Because the other thing that's part of the examination is you're not just looking for lumps, you're looking for skin changes as well,
Okay.
which are quite subtle sometimes.
Okay.
So
So if you're kind of not looking sort of down, if you can't see it fully, then yeah.
I don't know, very few people can look underneath
No, you can't.
the nipple.
Oh yeah.
Right. So you need to be in front of the mirror to do
Yeah.
that. So I'm like, that's the best way. Go up close, lit room, very well lit, and just have a look and see. And the way you do it, you lift your arm up, and the fingers are doing this walking kind of rolling motion around the breast, behind the nipple as well, and underneath the armpit. Because the areas that people tend to forget is the area behind the nipple and the
Yeah.
armpit.
Okay.
And then basically you can isolate usually the superficial lumps. You
Yep.
can isolate it between two fingers.
Okay.
If you put a finger over it, you can kind of roll it.
So it's a rolling type of
Kind
lump.
of, yeah.
Okay.
It's like you could put it over, you could kind of feel it like on its own, like it's
Yeah.
its own entity. And then the deeper ones are a bit trickier because all of what you could feel is just a slight bump, like a road bump. And what you can do to help increase your accuracy is you have two breasts.
Yeah.
Does this side feel the same as that side?
I see.
So, yeah, the other things that I think women should be looking out for, the skin changes would be pulling, so dimpling of the skin,
Okay.
pulling of the nipple. Skin starts to look like an orange peel, so quite pitted looking.
Okay.
Nipple discharge, especially bloody, but any type of nipple discharge of any color outside of breastfeeding, just
yeah.
get it checked.
Yeah.
And if one breast suddenly changes in size, be it increases significantly or reduces significantly compared to the other one, they're not the same. I know every woman tells me her breasts are not the same size. I appreciate it, but I'm talking significant change in
Changes.
size.
Yeah. Yeah. Like, and would you notice that something like over time, or is it like a specific time frame?
No,
Or
you could it could be something that's like slowly happening that
Yeah.
suddenly you're like, oh,
oh,
well,
that's a
this
bit
one,
different.
This
Yeah.
one's starting to look much smaller. This one's starting to look a bit bigger. So, and then
Yeah.
there's certain ones you can't miss. Like if it becomes a really big, red, hot, painful breast, then obviously
Something's going on.
something's going on. Yeah.
Yeah,
So
yeah.
definitely get it checked.
Yeah. And I think you touched on it a little bit just with the cell check, sort of the hormonal fluctuations. I mean, naturally breast tissue is
Absolutely.
sort of lumpy. And, if you're not really sure what you're looking for, you might get confused. And it's one of these things that, how can you differentiate between just the general lumpiness of breast tissue and something a little bit more that, something that you would probably need to get it looked at. Just
I
that
think
sort of,
It's quite hard,
yeah.
to be honest. Depending
Yeah.
on the type of breast, it's quite difficult.
Yeah.
Because you get a lot of women complaining of palpable lumps, especially in the outer part of their breasts.
Yes.
Quite common. That's the densest breast tissue that we have is going to be in the upper outer part of the breast.
Okay.
And it does change in size with hormonal changes. So that's quite normal. The problem is if it's a new symptom, if it's a new area that you're not sure about, I think the safest thing would be to honestly just get it checked.
Yeah.
I think
And especially if you've got the red flags that you were saying.
Oh, yeah,
the
yeah.
skin
I mean,
changes.
that's a given, right? But
Yeah.
if there's anything you're not entirely sure, and I always tell my patients, if you're not sure, you've lost a night's sleep, you have a gut feeling,
Get it checked out.
get it checked. I think
Yeah.
because you know your body best,
Yeah.
and it's just way easier. The exam coming in, getting it done doesn't take very long,
No.
right? They might not necessarily need a mammogram.
Yeah.
It might just be a simple case of seeing a breast surgeon, getting examined, getting an ultrasound, especially if they've had a recent mammogram and they're over 40. So just because a woman is under 40 or over 40 and she's had a mammogram, say 3 months ago, and she's felt something new, 3 months later, it doesn't mean she shouldn't come in. Come in, get it checked anytime. Yeah.
Well, I mean, I feel like, again, I go back to a personal point. I was a bit worried
Yeah.
just because of a family history. And I came in and I saw a breast surgeon first, and she did an examination and said, gave me an all clear. But then she also, just to be on the safe side,
Absolutely.
requested a mammogram, not mammogram, an ultrasound. And that was that. And honestly, I walked out of the appointment with you feeling
I'm glad.
light as a feather.
Yeah.
It was really sort of in the back of my mind, and especially, again, women, mothers, parents, grandparents. There's a lot, life is full, and you've got so much going on, and all you want to do is just don't carry the burden when you can go and get it checked.
Absolutely.
Yeah.
It's just not worth it, honestly. Like, the worst thing I think ever is if someone's going to sit back and think, I wish I had this checked
earlier. Yeah.
back
Just
then
do it.
when I felt it. And because I don't know, like, I can never ever ask a person this, obviously, because it's a personal journey that everyone goes through.
Yeah.
But I would find it really difficult if it was myself and I felt this and
I could have done it.
And I could have done, it would have been different.
Yeah.
The outcome is different.
Yeah.
So just, don't make your decisions that you don't regret them.
Absolutely.
That's my advice. Like, if you're going to sit there and regret it later on, it's just not worth it.
Absolutely.
Yeah. Peace of mind is
worth more than anything in this
it's worth
world.
its weight in gold. Like,
Absolutely.
it's just not worth worrying over stuff. Yeah.
Yeah. You touched a little bit about mammograms. We hear mammograms as being the go-to, so the golden standard. Is that something, then on the flip side of the coin, you'll hear people sort of worried about mammograms because of radiation.
Yeah.
Is it a safe diagnostic tool?
Yeah.
Okay. And
Yeah.
this is the golden standard.
As of yet, still,
Yeah.
it is the safe golden standard. What happened is, years ago, obviously the radiation doses would have been much higher.
Yeah.
The technology has improved, thankfully, right? So there is obviously radiation because it is X-ray, but it's quite low compared to what it would have been before. Living around us, if you go out of your house in a car, if you go on a plane, there's radiation all
Inherent
around
radiation,
us. There
absolutely.
is background radiation. This is a known fact. So there is obviously going to be some radiation, but we always look at, when in the medical field, we look at risk versus benefit. What is the risk? Can we live with the risk of someone developing a breast cancer if we can save X number of women who have breast cancer? So where there might be a very, very small risk of someone developing from the radiation, because the risk is always there. There's no guarantee in life, again. It far outweighs the risks that would have been involved if all these women who'd been walking around hadn't been screened and they had breast cancer.
Yeah.
And it would have just developed and had time to grow. So
Yeah.
absolutely. Yeah.
Then you couple it with ultrasound.
Yeah.
Okay.
Especially for dense breasts, I think.
Yeah, I guess that was now sort of, an added layer of difficulty. You've got this term that I've read, which is dense breast. Number one, what is it? What does that mean? Because it has been something that sort of, you hear about it, and I read about it, and I wasn't really sure who has dense breast. Is it a size specific thing?
No.
Yeah. So it's a
lot of women have this misconception.
It's confusing.
I have really small A-cup breasts.
Yeah,
how do I have dense breasts?
Yeah.
But you do. When you look at a breast, it's composed of two types of tissue: fat and breast tissue. When we talk about breast tissue, breast density, we're talking about the ratio of breast tissue versus fat. So the denser it is, the more breast tissue you have and the less fat you have. And then the American guidelines are broken down into 4 categories. So the type A, ACR type A, which is see-through breasts, essentially. It's just fat, fantastic, my favorite type of breast. If there is anything in it, we will find it. Yeah. Then you have the type B breast, which is about 25% breast tissue, and you have mostly fat. So again, still very easy to look at. The challenge now is in the C and D type breasts.
Okay.
Because you can have what we would call like mixed density, so quite not completely dense yet, the C type. So mixed density, there is some fat, but it's a mishmash. It's very difficult to
And that's
interpret.
to clarify, it's not C and D sizes. This
No,
is just the category.
The category,
Yep.
C and D. So
Yep.
category A, B, C, D.
Yeah.
The D, the best way to describe D-type breast is, the fogs in Dubai?
Yeah.
Fog,
Wow.
essentially. It is purely white. You cannot see through it.
anything.
Very challenging, but to overcome those challenges, obviously, especially for the C and D-type breasts, we as part of standard practice, add tomosynthesis,
Okay.
which is we take slice images through the breast in two views, in the mediolateral oblique view and in the craniocaudal view. So in both angles that we're taking it, we have your standard conventional mammogram and you have two views of slice images, for lack of better words, essentially your CT scan through your breasts. And what that does, it helps kind of pick through it a little bit.
Yeah.
So if there is anything like a small area of distortion, you can kind of see it as well, because sometimes cancers can show up as distortion.
Okay.
And then when you couple it with an ultrasound, you have those are the breasts that I spent longest looking at.
Yeah.
And I'd nearly go through it twice, to be honest, is just to be on the safe side. You go very slow and you have to like really pick through every single part that you're scanning and you're looking at, and just treat it as potentially there's a cancer there. I need to find it. There may be nothing, which is fine, but I always treat these breasts as I don't want to miss whatever is hiding in here.
And that's the biggest challenge.
That's the biggest challenge.
Okay, sort of the imaging side of it.
Yeah, absolutely.
Gosh.
Yeah.
How would you know? Is it just purely on ultrasound?
Well, no, I mean, you have the reassurance of the mammo that there isn't anything that's really sticking out. So what the mammo does pick up is, like I said, the areas of distortion. So the pulling of breast tissue, and it pulls in kind of like a star formation, I think is the best way to think of it.
Okay.
So it pulls in, and there's like or you can think of it as radiating bits of breast tissue radiating lines from it.
Yeah.
And then and then it also looks at microcalcifications. So there's normal microcalcifications. You and I probably both have. If we bring 10 women, they probably all have a fleck here or there.
Yeah, my mom has. So it was it was picked up on ultrasound. We were very worried, and then it was explained that it's completely normal.
You can, and sometimes you can see them on ultrasound as well, and you can definitely see them on mammogram. And it's really looking at the distribution of microcalcification and the type of microcalcification. So that's usually what makes us decide: is this normal, or is this something that I should be worried about or need to sample? So so it does help. And then you also look at the skin thickness as well on mammogram, which you can appreciate really well. So you can see, there's an area of thickening here. Behind the nipple is very challenging on mammograms. So that's where the ultrasound's really helpful, because you can better discern what's going on there with an ultrasound. You're having a direct look, essentially. So they work together and they help answer different questions. So the best you can do is have a good look. If you're not sure, get a second pair of eyes, and then do the scan really slowly and take your time with it, because you don't want to miss things.
Can a patient know that without an ultrasound or any of these imaging platforms that they have sort of dense breast? Or is that what I'm trying to say? I mean, is it something that you can feel, or no, you wouldn't know until you get potentially a scan?
I mean, it's quite difficult, because how would you describe the feeling if you've never known what a dense breast is, or what a fat only breast is?
So there's no sort of physiological sort of
way
touch
of doing
point.
it. No.
It's good to know. I mean, it's one of these things that you think, I've got this, and they've already categorized themselves as something.
I mean, there are big-breasted women who have very dense breasts. There are big-breasted women who have fat-only breasts.
Yeah.
There are,
and likewise with
and exactly with the smaller-chested people, like they think that, but how? I'm like, you do. And I show them their mammograms. I always sit and explain, like I show them the images, because it's easier with the pictures. You're like, and this is it.
Yep. I think a lot of it as well, you do pick up. I mean, we've gone to sort of breast cancer and sort of malignancy. But on your routine scans, whether it's mammograms or ultrasound, you do pick up other, whether they're cysts or something, maybe a tumor that's benign. Is that the correct way to describe it? Is that common? Yeah. Something that, generally, I mean, is there something that needs to always be monitored? it may not start off as a cancer?
So
I think that's also a big
so
big topic. Yeah.
it really depends, right? I mean, a lot of it is based on age of the patient, what you're seeing as like if it's a cyst and it's just a bag of fluid,
Yeah.
I'm not interested in these. I think they're because they can come and go, right?
Yeah.
Unless it causes a problem where it gets infected. So what I tell my patients is that there's 4 things that happen with cysts. They either stay the same, they go away, they get bigger, they get infected.
Got it.
So, and where they cause problems is when they are getting bigger because they're stretching the breast tissue. So the pain isn't in the cyst itself, it's in the stretch it's causing in the breast tissue.
Yeah. Some sort of inflammation in that area.
It's just you're pulling on hormonally sensitive tissue. It could hurt. And then if they get infected. So I offer aspiration of cysts only if it's cosmetically causing an issue. So sitting at the end of the bed, I can see that, oh, you have a mound
Yeah.
on your breast and it's not the same on both sides. And then I go in and it's a cyst. Do you want me to drain it? Then that's fine. If it's infected, obviously, yes, I would drain it as well. So those are cysts, that's as exciting as they get. But then you have other kind of benign solid lesions. So you have things like fibroadenomas, you have things called hamartomas, lipomas. So lots of omas. But, they're depending on what they look like and, the patient's age and their appearances on ultrasound. For the most part, we tend to follow them up, right? We don't necessarily, not all of them need a biopsy. Anything that's rapidly growing, that needs a biopsy.
I see.
Things, lesions in certain areas or nodules in certain areas, I like to biopsy. So if it's like a solid lump that's behind the nipple that I'm only seeing on ultrasound, I like biopsying those because they could be one of those indeterminate lesions that I'd mentioned before, where it's not a cancer, it's not benign, but they need to come out.
Yeah.
So they're those on the fence lesions, which we call B3 lesions, which is a histology grading.
Okay.
So, and it's very difficult just on ultrasound to give a patient an answer on those ones that are behind the nipple and in the ducts as well, because you can get sometimes areas of growths or, a solid component that's in a duct that's behind the nipple. Those would need a biopsy, yeah.
Okay. And biopsies can be done in the clinic? Is it a sort of a
it's
day
a day
thing?
case, absolutely, yeah.
Yeah.
It's
You hear biopsy and sort
yeah.
of a wave of anxiety comes
Oh,
over
yeah.
people. And I just
Yeah.
sort of wanted to touch on that it's not as scary as
No.
it sounds.
So I always ask my patients if they've ever been to the dentist, and obviously it's shock horror. Yes,
Yes.
it's a horrific experience. I'm like, it's not as bad as going to the dentist.
I hate going to the
I
dentist.
also hate going to the dentist. I love them. I love my dentist. She's amazing.
Same, yeah.
But I hate going
Yeah.
there. So I'm like, it's not as bad. The only thing we have in common with dentists is we use local anesthetic.
Okay.
And what I tell patients is 9 times out of 10, you won't even feel the needle going in when we're giving the local. It can sting, but it takes away the pain.
Yeah.
We cannot take away the sensation of pushing, pulling, things like that, but pain, absolutely yes. Very straightforward. The biopsy needle, unfortunately, still makes a very loud stapler-like
I've
noise.
heard it, yeah.
Yes,
Yep.
and which can be unpleasant, and people may jump, but I always
But it doesn't
demonstrate.
essentially hurt.
No, it doesn't.
Yeah.
It doesn't.
Yeah. It's
a
just it is a
it's a
loud
painful
noise.
sound.
It's a clack. Yeah.
it's a
I've
painful
heard
sound,
it.
but
Yeah.
it's not painful.
Yeah.
And it can be a shock if they've never heard it. So
Yeah.
if I'm going to go ahead and do it and not demonstrate it, not a good idea.
No.
Because I don't want them to jump.
Yeah,
That's
fair
definitely it.
enough. Yeah.
And that's straightforward. Like you take 2 or 3 samples, sometimes more if the sample is fragmented, which means it's not enough tissue coming out. I make sure I take enough so I'm not bringing the patient back.
And so you have I've seen it done only for an FNA for
Yeah.
thyroids, but you've got your histology team with you as well, just to see if the sample is the
No,
same.
no,
or
I
it's
look at the
completely
sample.
different.
No,
Okay.
no, no. So it's a very different
Okay,
process. Yeah.
okay.
So what we do is it's a core biopsy. So we're taking a chunk of tissue.
I got it. Okay.
So it's a needle that goes in. It's very sharp tip, and what it does is it cuts the tissue and puts it inside, and we take it out.
Got it.
So we get essentially it looks like a tiny worm.
Okay. Yes. Got it. Yep.
Yeah, so it
Yeah.
looks like that, and I look at the samples because sometimes the sample can be like falling apart,
Yeah.
fragmented.
Yeah. So you'll go and maybe
and I'll
get
take a
another
couple of
number.
more because I'm like, you're numb, you don't feel anything.
Let's get a good.
Let's get a good sample because I
sample.
don't want to bring you back, and you don't want to come back,
100%.
right? And then what we do is always we leave a clip in there to prove that we've taken a sample from the right place.
Okay.
And if they're getting a
Almost like a
mammogram,
little GPS marker.
absolutely,
Yeah,
it's your pin drop
Yeah,
Google
yeah,
map thing.
yeah.
Yeah, so it's just it stays
Gosh.
there.
That's brilliant.
And then patients surprisingly forget 10 years later they've had biopsies done. So when they get, so if someone's had it at a young age, this biopsy, and then they're going for mammogram, say at 40, whoever's looking at their images at that point is like, oh, you've had a biopsy there.
Oh yeah.
Oh yeah, I did, and that's one way to prove that that area has been biopsied. So it takes the guessing game out of it as well.
Gosh, they've come a long way, huh? Yeah, that's amazing. That's so good, and it makes life easier that you could potentially be anywhere in the world, and you know exactly where you've potentially biopsied.
Yeah, absolutely.
Yeah, amazing. It's really, really amazing. And I think my next question would have to be about. We touched on it slightly at the start, but it was all about the epigenetics. So lifestyle factors, things that could potentially, everyone is always wanting to improve lifestyle in order to override their genetic predisposition. Do you find that can it potentially reduce the likelihood of cancers?
Yeah, it's risk reduction.
Okay.
So everything that is done is about risk reduction. The
Yes.
risk is there,
Yeah.
but where it may have been a 40% risk, it becomes, say, a 35%, then it becomes a 30%, then a 20%. It never becomes 0% while we're living and breathing.
Yeah.
There's risk is always there,
Yeah.
but it's all about reducing the risk. So yes, healthy lifestyle, obviously, keeping a check on the BMI as well. Being overweight isn't really helpful.
Yeah.
Smoking is also linked.
Yeah,
Alcohol is
alcohol.
also linked. Being kind of
Aware.
aware of, or like kind of like vigilant in terms of like when you're taking your oral contraceptives, right, and your hormone replacement treatment, that there is that added risk as well. I'm not going to sit and tell women go and get married and have babies.
Yeah.
That's a personal choice.
But you need to understand.
Unfortunately, right, the longer we are exposed to our own body's hormones, the likelihood is higher. Like, and not breastfeeding also increases the chances. So there's a whole amalgamation of things that can be done.
Yeah. And just in terms of the hormone, are we talking specifically estrogen?
Yes.
Or a couple?
So it's estrogen is going to be the main one,
Okay.
right? So that's the one that we're going to be would
A
have been
little bit more.
exposed to for the longest time. So if anyone says had a period at the age of 9, which unfortunately now most girls are having their periods much earlier.
And that, sorry, just to cut you off, I'm just trying to think, is that why maybe the breast cancer sort of occurrence is happening a bit younger?
Yeah, there's a whole bunch of, most of it is hormone related, right? So it's the having the periods start early, the not having children, because we have a huge population of women now that are in the workforce and not interested in having families, not having breastfed, or may have been on contraceptive for other reasons, and that have periods till much later on and have had to get HRT, and in our foods as well. There's hormone injected.
And those things are all, they are choices, but I think it's good to keep them in mind to
absolutely.
check.
Yeah.
Not so much don't do those things.
No, live
It's
your
just
life.
Live your life and do what you need to do.
Yeah.
But just be mindful that they, no matter what, are going to potentially may increase the likelihood. So be mindful and check.
Absolutely.
Yeah.
Yeah. If you're not sure, check. Get yourself into the habit of, I'm going to, especially at 40, I think, that I'm going to do this every year.
Yeah.
And I'm just going to pick one day of the year and say, this is my breast day, spa day. Give yourself something to look forward to afterwards.
Put on a mask and do a self-check.
Put on a mask.
Yeah.
Go get a self-check. No, get the self-check first and then go have something nice done for yourself afterwards as a treat. To give yourself that pat on the shoulder that you did something that was really stressful with a lot of anxiety behind it, which is very understandable, but you've done well. It's out of the way. You can tick that box. Continue.
I love it.
Yeah.
It's almost like necessary self-care.
Absolutely.
Yeah.
Yeah. Life's too short to
Just
take yourself
sweep
for
it
granted.
Yeah, and sweep it under the rug. No,
Yeah.
it's there. Let's just talk about it and do what we need to do to protect ourselves. Yeah.
If your check engine light's on, you're going to get your car checked.
Absolutely.
Why wouldn't you get yourself checked?
Absolutely.
You're more precious than the car.
That's right.
Yeah.
You take your car in for service every however mileage or the 6 month
Exactly.
mark.
There's a service on us as well.
Absolutely. I on a previous podcast, it was the same type of check yourself when it comes to sort of pelvic floor and things like that. This is your car. You might as well just
That's
make
the
sure
only
you
car
service
you have.
it.
This is it. You have no other choice. That's your ride.
Yeah.
Enjoy it.
100%. I'm with you.
Yeah,
I'm with you. this is a bit negative. I think I was just reading the statistic it's quite alarming.
Yeah.
I read apparently that breast cancer is probably the most common cancer worldwide. And the number, which hit about 2.3 million across the world,
Yeah.
of women developing breast cancer, it is on a rise.
Mm-mm.
Why do you think that is the case? Because of probably all the reasons that you mentioned earlier. Yeah.
Essentially, that's it, right? I mean, there's a lot of stuff that's going into our foods nowadays.
Oh, I think that's a whole nother.
That's a whole other topic,
Yeah.
right? That we don't know the long-term effects of what the outcome is going to be. And again, development is going to be different, right? You have people living longer as well. The healthcare is better. So where someone may have died, say, from blood pressure 20 years earlier, they're alive longer. And because they get to enjoy that extra few years, that risk of then developing
increases
naturally, right? So especially as we age, so the older we get, that's one of the main risk factors of, when you think of breast cancer, is just aging. Yeah.
Which is unavoidable.
Thankfully, right? I
don't want to live forever. Yeah.
I'm all for it.
Yeah.
I'm happy to age.
Brilliant. I've got your top 3 recommendations for women, obviously in the month of October, and sort of moving forward for the rest of their lives. Do you have sort of your top 3 goals or top 3 recommendations you would give women?
So for me personally, if you haven't yet had a mammogram or had like a conversation about it with someone, get it done. It's not as bad as you think it is, because so many patients, when I ask them after their first mammograms, how was it? It's not as bad as most people say. So that's the testament of women who have it for the first time. And then once you've done that, keep checking.
Yeah.
It doesn't stop with just having a mammogram. Be vigilant. Once a month, anything new you're not sure, get it checked. Then that's the other one. Get it checked. Like if you're not sure, don't sleep on it.
Yeah.
Don't leave it and just worry or think it's going to be fine. It could be. I hope so, right? And that's what we all hope. It's going to be fine. But just get it checked for your own peace of mind, because you don't want to have that as a regret at the back of your mind. Had I done this?
Of course.
Nothing worse than that.
And it's almost doing things like this, sort of speaking about it, talking about it. Don't be worried and sort of hide it away, and
I mean, it's easier said than done. Different personalities are, again, you have to take people's personality types into consideration, which is why I think it's just keep an open mind. Like when you come in, it's not doom and gloom. I've the number of patients I've had breaking down crying after a normal exam is phenomenal. Like, and I completely understand. I need to walk around just with a box of tissues, because it's just so normal, that relief that washes over them.
Absolutely.
That anxiety escaping the body. And it's almost like an adrenaline crash.
No, but I mean, it's true. Again, I can only speak from a personal point of view. I mean, I'm 37.
Yeah.
And when I walked to your clinic, and I felt like I was shaking like a leaf. And I was just sitting there thinking, like, I've got 2 little kids.
Yeah.
Like, and once you said everything looks good, I just honestly felt, number one, you do get quite emotional.
Yeah, absolutely.
And then, I mean, past that, you just feel so much lighter sort of walking out. But I understand, because you feel this immense feeling of relief once it goes smooth.
Absolutely.
But then on the flip side, should there be something, it's good to know that you will be well taken care of.
Absolutely, yeah. The thing is, always tackle it one step at a time, right? So I cannot tell you what's going to happen in 3 years' time. I can tell you what we need to do now.
Yeah.
So we take the first steps, and I can tell you what these couple of steps are. You won't have the capacity for all the other steps at that moment, right? All we can do is tackle what is in front of us right now. Let's deal with this. Find out what we're dealing with, because that makes a difference in how we go forward. So a lot of the times I cannot just give you the answer. I can just say, I'm not sure, I'm worried. But once we get a proper diagnosis, that's the difference.
Yeah. This brings us to the end
Yeah.
of this amazing episode.
I know.
Thank you. But I
thank
always
you.
sort of end the episode with any of your favorite saying or a quote.
Yeah.
Or anything that you have in mind that you kind of always use, or it's always in the back of your mind.
So there's one quote. I even had this in front of my door when I came home when I was living in the UK. and it's Sherlock Holmes.
Okay.
And it's basically pure doctor, right? So
Yep.
once you've eliminated the impossible, whatever remains must be true. And it so fits medicine
absolutely,
and what we do,
absolutely.
because that's essentially it. It's about breaking things down and then coming to, okay, well, what can this be? It can only be this. So, yeah.
Brilliant. I absolutely love it. It's so fitting.
Yeah.
And of course, if any of the listeners would like to do or like to have a consultation, I know that MediClinic has an incredible team, of course, with
Absolutely,
you
yeah.
in it. They'll just have
Thank
to
you.
call and make
Yeah.
an appointment. And
Absolutely, yeah.
they will be in very, very, very safe hands.
Yeah, no, absolutely. There's a whole team. It's not just me. There's a whole team
Yeah.
behind me as well. If there's anything that needs to be done, there's
You've got all hands on deck.
all
Yeah.
hands on deck.
Yeah.
All the specialists, all the relevant specialists are
Yeah.
there. So that's the main thing. And that's where you'd want to go, where all the specialists are.
Absolutely. Brilliant. Dr. Maha, thank you so much for
No,
your
thank
time.
you.
I truly appreciate
Thank
it. There was
you.
so much very, very useful, very practical information. And I really, I'm so, just because I had a special interest
Yeah.
of it, just with my own sort of family history. And I just thought, I'm really thankful for all the information. It's been,
Oh no, my pleasure.
it's been
Absolute
a
pleasure.
huge benefit.
Hopefully this will help some people as well.
Oh,
with
I'm sure it will. I'm
going
sure.
forward, so to kind of ease them into
Yeah.
getting started.
Yeah,
I think
yeah.
once you start,
That's it. It's taking the first step. That's definitely, I've noticed that the first step is the hardest and the scariest.
100%.
The moment you walk out thinking that wasn't so bad.
Exactly.
Yeah.
And then most people do that. They're like, okay, you see that? That was your first step. You've done it now.
Yeah.
Now, every year.
Perfect.
And it's that straightforward.
Yep.
Yeah.
Great. Thank you so much, Dr.
No,
Maha.
pleasure,
I really appreciate
pleasure.
it.
Thank
you for
you.
coming on.
No, thank you so much.
My pleasure.
Thank you for listening to They Say It Takes a Village. I hope you enjoyed today's episode. I look forward to bringing you another one next week. Don't forget, please subscribe, rate, and review so I can reach and help even more parents. And if you've got a topic that you'd like me to cover, please head over to my Instagram page, ittakesavillage.me, and drop me a line.